Simon's Family Studio, and it's a delight to be back with you this morning. On my right is the ever faithful Hawkeye, back to help enlighten us more about all things infectious disease related to coronavirus. And on my left is a good friend, Douglas Girard, the Chancellor at the University of Kansas, and a physician here at the University of Kansas Health System, an outstanding ear, nose, and throat surgeon, cancer surgeon, actually. Quite a long track record. Did a lot of great things as chair of ENT, became the executive vice chancellor on this campus, and is now the chancellor at the University of Kansas. And back in our Studio B is Chris Wilson. Chris is the vice president for systems integration and innovation. Chris has done great work with the KU Lawrence campus. They're trying to help set up the testing program and things that we're doing to try and keep the campus there safe. So we're delighted to have this terrific team with us this morning. But before we turn to them, Dana Hawkinson, how is it?
I think it's pretty good. You know, I think we've reached.
It's better than what you said just a minute ago before we started the broadcast. You were like, "Oh,
that was a different topic." It was still COVID. Fear not, it was still COVID, but it was a little bit different. As far as hospitalizations, though, I think we're doing good. I think we have currently, and again, we've talked about these numbers are going to fluctuate. Months at a time,
weeks at a time, days
weeks at a time. Yeah. You look right now, it's a lot different than it was a month ago. Right. So right now, I think we are in a good equilibrium. Again, we want as few as people in the hospital as we can have. I think our equilibrium is going to be 20 to 30 for the foreseeable future. Now, what happens when it gets colder and all these people that are outdoors in these gatherings are going to be indoors in these gatherings?
That'll be a big change.
That'll be a change. So, but right now we are doing really good. Acute infections, we have 20 patients in the hospital.
Yay.
Yeah, which is really good. 5 of those in the ICU and only 1 on the ventilator. But again, as we talked about yesterday, we do have 5 people who are still on the ventilator who are out of that acute infection period and more in the recovery period. So, as we have stated, once you do get on the ventilator, it does take some time to come off. We do have another 32 people in the hospital who are in that recovery period as well. So as we talked about yesterday as well, it's 50-plus beds that are taken up that really wouldn't otherwise be taken up here in the hospital.
Yeah, so a total then of 50 beds, as you said, and that's still better than the 70 or 80 beds we were at one time.
Yeah,
so
absolutely.
We like this number better, and we hope it continues to go down. And the reason it would go down is because all of you do the right thing. Wear your mask, stay distance, wash your hands, cough at your elbow, and stay home when you're sick. How's that going to work, KU?
Going great.
Actually, the on-campus stuff is going really well.
It is. You know, you walk around campus right now. We're in our 4th week of classes. Hard to believe. And you walk around campus and it feels like summertime. I mean, we've de-densified the campus significantly through a combination of different course offerings, both online, hybrid, and in person, and socially distanced out the classrooms and the dining halls and all the facilities. And the team's done a really good job of creating a safe environment on campus. And compliance has been great. Mask compliance inside and outdoors has been really great on campus.
And that's what we keep reading. I mean, we have Amanda Gardner goes over and does some spot checks now and then, and she keeps going back and saying they're doing really well.
They are. I'm really impressed with how everybody's doing and towing the line. And we've had some issues off campus, but on campus we're doing well.
So, and how's the overall positivity rate of the campus going?
Well, you know, we as I'm sure we'll talk about a little bit later with Chris, we've transitioned now from our entry screening where we tested literally 23,000 people as they came back to campus. That's faculty, staff, and students. And really that number was under 3% as we do that mass testing. But now we're getting into more targeted testing, symptomatic testing, and then targeted surveillance testing and prevalence testing and some targeted hotspot areas. So we know it's going to be higher with that strategy than it is, and it's going to be, I think it's around the 10% range right now with that strategy now.
Yeah, which is kind of similar to our strategy, really. So Chris Wilson, talk to us a little bit about some of the dynamics of that, what's going on the campus, and what kind of things has the health system done to help support KU?
Sure. So as Dr. Girard alluded to date, we've had over 26,000 tests that have been conducted on campus, which is a pretty remarkable number. And to date, that's about a 3% positivity rate. And as Dr. Girard mentioned, over the last week or so, we've seen 85 positives through our testing, and that's about a 10.9%. A lot of the reasons for that are because we are doing more targeted testing among close contacts, some hotspot testing, but also the symptomatic testing has increased. So as you might imagine, as more people come and live together in locations and socialize with one another, you will have more symptomatic individuals. And so we have seen an increase in the symptomatic testing that to date has gone through the Watkins Health Clinic there on campus. But as we noticed that as a trend, the health system partnered with the campus and are happy to be able to bring more actual testing capacity for symptomatic individuals to campus. And so today is actually the first day of a new drive-through symptomatic swab clinic that we're opening on campus in partnership with Watkins and the rest of the campus leaders there. So just another reason why we need to continue to emphasize testing as an important resource, one of many resources in the portfolio of things that we use to battle COVID, but testing is certainly one of the primary resources that we need to continue to monitor and add capacity to make sure that we're doing the best to keep everybody safe.
Yeah, and I think that's great work. So I'm impressed. You read all about how campuses are doing across the country, and I just, okay, I'm really biased. I know the people involved, and I went to Mizzou, but now I'm a Jayhawk, and I look at this, and I think we're doing really good.
We are, but we're learning and evolving. And as Chris just mentioned, what we recognized as we made that transition from entry testing to ongoing testing was that the symptomatic testing volume was going to go up.
Of course.
And we did not have the capacity to do that really at Watkins to manage that growth. And so in less than a week, your team with Chris at the helm there has been able to stand up a whole new site to do symptomatic testing, which is different than our entry testing, which was the saliva test, and that's a little bit easier to spit up and hand it to somebody than
it's not a brain biopsy.
doing,
it feels better,
than doing the symptomatic testing, which is still a nasal swab. So it's a little bit more involved. And so adding that capacity and then probably maybe even more important, adding that capacity over the weekend, which we did not have the ability to do, is going to be huge for us. So our goal is if somebody has symptoms and they need to get tested, we want them to get tested within 24 hours because we want to know the answer.
So talk to us about the balance between off-campus and on-campus. How do you handle sort of the off-campus housing where we know there's more parties? We've all seen the video posted on Twitter and things.
Yeah, I mean it's a challenge. We have all our policies and everything in place, and as I think even the city manager said last night, we sort of built everything around compliance, and when you don't get compliance, that then challenges the system, and for better or worse in the state of Kansas, public health orders have been decriminalized, so really law enforcement does not have a role to play there. And so trying to figure out what levers you have to police these things, not literally police, but to manage these things. We're in discussion. I mean, it's a community conversation and a community effort, and of course, education is a big part of that. We would rather be proactive and just prevent these things and have to deal with them, but we recognize that's going to be a struggle going forward.
Well, and it feels like everybody would say, well, gosh, those are KU students, you have to do something. But the reality is they're living off campus. They're going to school, but it's like no different than somebody who's living at home and is a commuter. I mean, you have limited levers. Right,
and we have, student conduct policies that we can put in place. Of course, that's after the fact and doesn't really help you address a potential spreader issue that's ongoing at the time. And so I think that's just people's frustrations is they when they see behavior that is putting the rest of the community at risk, somebody needs to do something about it, but we're still struggling a little bit to define what that is. But the city's considering some options, including creating a municipal ordinance that would give some more opportunity there. So they've been great partners. The city and the county have been great partners through this process, as been the Chamber of Commerce, and we're all in this together. So we're all trying to find a way through it. And
businesses need to stay open, the community stays open, the university needs to stay open in order for everybody to thrive, but got to do it safely.
And I think to your point, from day one when you called Steve up and we got the team together and the boots on the ground there, you were concerned with what can we do to make our students and teachers and faculty and staff safe on campus. And I think there are great systems and protocols in place. It's a problem, and we saw an article about this the other day. Even the modelers didn't predict for when somebody knew they were ill going to these places, whether it's an off-campus party or a restaurant, not otherwise doing masking or social distancing. Right. That's when the real danger comes in, and you don't have a lot of control over that. And unfortunately, that gets down to personal responsibility, and we've kind of seen how that turns out a lot of times.
But if you're doing the right things, even if you're in the presence of somebody who is symptomatic and positive, if you're wearing your mask and you're washing your hands and you're keeping your distance, you should be okay.
Yeah.
You should.
And I think we've proven that within the health system, as you guys have been fully operational in a COVID hotspot for 6 months and not really had transmission at work. I mean, we know you can do that. You can protect yourself even in a high-risk environment. So while it's frustrating to have other people not doing what they need to do, if you're doing what you need to do, you really can at least protect yourself.
Yeah. And Chris Wilson, are you protecting yourself? You're doing a good job out there?
Doing my best, Dr. Stites. So I think the vibe on campus in and around Lawrence is, people have just general increased awareness and improved practices from an infection prevention standpoint. I mean, when you look at going to the grocery store or walking around campus now compared to, a month and a half, 2 months ago, it's night and day. There's some really great progress that's been made locally there in the Lawrence and Douglas County community. I think big kudos need to go out to the Douglas County Health Department for all their hard work to get us to that point as well. But there's, still some opportunity, and we saw some of that publicly, unfortunately, this weekend. And I think that that's just something that we continue to need folks to recognize the importance of adhering to the social distancing, masking, and other infection prevention measures are going to be the real key. Individual adherence to those are going to be the real key for us to be successful through the rest of the semester.
Yeah, somebody said that college students don't always do pandemics well. I think that was a Chris Wilson quote.
Yeah, I think that's pretty. That may be a paraphrase, but yeah, that's pretty close.
Yeah, it's pretty close.
Well, and Chris Wilson can speak to it directly because he is a Lawrence resident.
He lives there,
So
and
he sees it every single day.
Yeah.
Of course, but he still lives in Lawrence and sees it every day. So very in tune with our community, and that's been really helpful as we've tried to navigate through this, and including helping us put together our dashboard.
Yeah, so let's talk about that dashboard.
Let's talk about that a little bit. So one of the questions that we threw to the team was how best do we talk about our numbers as we do this, not just on the entry, which we've reported sort of frequently what those days' results are, but really we wanted a more longitudinal look at our numbers over time, thinking that that's going to give us better information. So thanks to the team, including the folks at KU Medical Center and in the School of Medicine, have really helped us with this as well. But Chris is really probably our local expert on this, and we might ask Chris to walk us through it.
Take a swing at this now.
Mm-hmm. Sure. I think the team's going to pull it up on the screen here. But what we wanted to do is there's basically two dashboards that'll get published on Tuesday and Fridays by the campus. And there's links to the website, I'm sure, that can be provided. But the basic idea is in the first dashboard is to look at everything that's occurred to date. And in the second dashboard, the one that's on the screen right now, is to look at the most recent 7 days. And so for each of these visuals that you'll see, we try to identify the total number of tests, the total number of negatives, total positives, and the positivity rate. Also, in the bottom left-hand corner there, try to keep track of what's going on in the community with rates in the Douglas County geography per 100,000 over the last 7 days, because this is as much as about keeping campus safe as it is about how does campus impact the Lawrence and Douglas County community as well. Also, you'll see there the testing results, both negative and positive by date. And we do that for 3 different areas or 3 different types of testing. So we have all of our testing included in one report. Then we have a separate visual that looks at just the entry and prevalence testing. And then a third visual, there's the entry and prevalence testing. And then a third visual that looks at the Watkins symptomatic testing as well. And as you can see here, the symptomatic testing positivity rate anticipated. So it's 6%.
So we're losing you, Chris, for just a second. Let's see if we can get that connection a little better because we're not hearing you from him. Hang on for just a minute. So, Doug Gerard, this protect.ku.edu/data, is that available to the public, or who can see that?
That is. If you go to the University of Kansas homepage, you'll see this giant block there that says Protect KU, and if you click on that, that will take you to the website that really has everything from all our policies, all the activities we've done to create a safe environment on campus, our data, and then the dashboard is there as well. But the /data will get you there directly if you want to do that.
Well, and I think what's impressive is that the university has said they're going to be honest and transparent, which exactly what this represents clearly. accurately. But also, I think we were making sure we had the right dashboard. You guys worked hard at it to put it together, make sure the information going into it is accurate, and so that nobody can question or say, oh, you're hiding something. That is just not the case.
And it's a challenge for all of us because the data comes from many sources. And so this dashboard, actually, and Chris can probably speak to it, has feeds from multiple different areas, not just us. And so that's a really important part of creating a holistic picture of what's happening. It's not just our numbers. It's looking at community numbers, Douglas County numbers, which some comes at the county and then some comes from the state, and it comes from multiple
students can be
different
tested in different locations, so they don't have to be tested at KU. So Chris, talk to us a little bit about how did you get all that information pulled together? How did the team?
Yeah, so there's multiple collection sources for testing that go into this. So you've got Watkins, you've got LMH, you've got the health system now, and you've got the saliva collection that has happened through the entry testing and prevalence testing. But you also have multiple labs that run that data. So you've got labs coming from the CRL lab, you've got results coming from the health system lab, from LMH, and also Douglas County. So we were able to actually get a feed from the Douglas County team as well. So it's one of the challenges in the pandemic is getting source of truth from a data standpoint. And without having that sort of readily available for the campus, we had to go out and identify those that we could get feeds from, and all have those come into a single dashboard for the campus to use to help inform its decision making.
So a lot of work there, Dana. Tell us a little bit, Dana, how do you think all this can be used to help keep the campus safe, Hawk?
Yeah, I think the biggest thing is that we now there's the partner with the health system, so we increase the capacity to test, and I think that is going to be one of the major factors moving forward. LMH was able to do what they were able to do. Watkins was able to do what they were able to do. We know what the health departments in general can do. Adding the more capacity for more testing, that way reaching out not only to symptomatics but close contacts of close contacts of known cases, just to get more testing out there. Again, the goal is to really understand the prevalence of the disease in the community. And I think if you do have that increased testing capacity with a good turnaround time, and we are providing, pretty good turnaround times. So far, all of the testing that has been done on the campus has had really good turnaround times. We are able to get a more clear picture of really how much the disease is in that community.
Right. Plus, if you have to wait 7 days to get a test back, you can't quarantine anybody effectively.
Correct.
You can't do all the contact tracing. So this is a big step.
Yeah, and actually, if you might touch on this, you mentioned about testing close contacts of positive cases. And there's always a little bit of confusion around this. And if you're a close contact of a positive case, you quarantine for 14 days, period.
Right. That is the ultimate guidance. Yep. Testing does not get you out of quarantine. However, there is also the theory or the direction of, if you are a close contact, can we test you to know earlier so that you can, continue to isolate yourself? That will affect your quarantine date as well. But then, so you also aren't out spreading it. Right. So, but when we haven't really landed, there's no real direction on when to test a close contact of a known case. Is that 1 or 2 days later? Is that 7 or 8 days later? Testing does not get you out, but again, it will give a more clear picture of the disease prevalence in the area.
And Chris Wilson, we're testing on campus 5 to 7 days out from a close contact. Is that correct?
That's correct, yes. So we erred on more from a conservative standpoint to be able to catch as much of the disease as possible. Basically, the longer you wait, the more likely it is that you'll be able to detect virus in the individual. And so for the close contacts, we're now using a 7-day time frame, which was informed by the county. They helped us come to that conclusion. And so the close contacts on campus that are seeking testing, we identify who they are when they come through a hotline or a Watkins phone call, but then ask them to wait 7 days before we collect their sample.
Chris, how should the public view the information, or Dr. Chancellor, how should the public view the information on the dashboard, and when should they be concerned, not concerned? How should they use it, and how should they process it mentally?
Well, I think it's just another factor that one needs to look at when you're trying to evaluate the safety of the community. I think that positivity rates are an important statistic to look at if you're looking from an apples to apples standpoint about the same population that you're testing. the challenges in the state of Kansas and really across the country is you have different communities testing at different intervals or different populations. And so it can be a little difficult to compare maybe another college town that might be testing only symptomatic individuals that would have much higher positivity rates with the KU campus that has tested entry testing, prevalence testing, close contacts, and symptomatic populations. So I think that the advice I would give is to compare the numbers to those at KU over time. And that's why we've included both the most recent statistics and all of the data to date in the two dashboards that get published twice a week.
All right. Well, let's see if there's questions from our listening audience. But first, we'll turn to media and see if there are questions from media.
Good morning. Yeah, I have two questions, Dr. Stites. This is Lindsay from 41. The first is we saw that University of Missouri has suspended and expelled students, Chancellor Girard, for violating COVID-19 policies. I know you said you were working on student conduct aspects of how the university might consider taking action. Is suspension and expulsion on the table?
Yeah, I mean that we have a sequence of events through student conduct. Our first actions that we've taken, the provost office has identified and done public health bans for folks at these places. So we had two Greek houses that got a public health ban based on activity, and now at least two houses that we saw have some challenges over the weekend now have the residents of that house have a public health ban as well. Repeated violations move further down the road towards suspension and then theoretically go all the way to expulsion.
And Lindsay, did you have another question? I think you said you had two questions.
Yes, sorry, I'm watching in stereo. I got to walk away from my computer. The other question relates to a story we're working on with someone who's a part of the vaccine trials. If you are a part of the COVID-19 vaccine trials, apart from placebo, are you to assume that that vaccine has COVID-19 in it? And is that something across the board? Do vaccines have some of that disease in it they're trying to protect from?
Yeah, that's a great question. So, Hawkeye, let's talk
Yeah.
a little bit about the science around those COVID-19 vaccines.
Yep. So for the vaccines, I think there are one or two that are inactivated virus, but those are not what you're hearing about in the regular news stories. For most of the trials that are going on now, these are going to be just pieces of the virus, specifically the spike protein. And whether that spike protein is put into another virus vector, such as the adenovirus, or whether it's just the protein itself, or whether it's the mRNA or the DNA as well. So the answer to that question is no. For the most part, it's not going to be the virus. It's just going to be that spike protein of the virus. And whether that's the protein itself or the RNA or the DNA, that is where a majority of these vaccine trials are right now. So it won't be the full virus.
We'll have an upcoming program on this too. When Mario Castro comes back, we'll talk more about some of the science. But I think a lot of it, and Hawkeye, correct me if I'm wrong here, when you get an injection, it goes into the muscle, there can be some localized inflammation that attracts cells in, and your body recognizes the stuff that got injected, and it says, doesn't recognize and says, hey, that's foreign. I got to develop antibodies to that.
Absolutely.
What you want is a lot of antibodies, not just a few antibodies to be developed, because you want your body to have both, and it's really got two prongs for a defense system. You produce antibodies, then you produce some humoral immunity, which is more chemically based stuff, and you want both things to occur. In order to do that, you've got to get enough of the antigen, or in this case, the foreign body, into you to really engender a pretty good response. And the way that can be done is through different mechanisms. The AstraZeneca trial that was halted, but has now been restarted in Europe, and we hope it restarts in the U.S. very soon. That trial looks like, as I understand it, it's a live adenoviral vaccine that's derived from monkeys. And so you do get infected with that adenovirus, but it's not one that's going to make you sick. I mean, they've very carefully chosen this adenovirus because it contains the spike protein, and it can make your body engender a pretty strong immune response to that.
Yeah, absolutely. So that trial is the adenovirus vector, or the main delivery mechanism of the payload, and the payload in this case, again, is going to be the spike protein. That's the only
Sounds like
part.
a space shuttle. Now we're talking payload.
I know, right?
Okay, go ahead.
Put it in normal terms so people can understand how this is going. And in a lot of these, so that was the adenovirus vector. Again, the payload, what we are trying to make your body recognize as foreign to develop the antibodies to develop the T cell responses is the spike protein. Same thing with the other trials as well. For the most part, again, it's either the RNA or the DNA or the protein vaccines themselves, but really no full COVID virus.
Yeah, you're not getting COVID-19. Let's put it that way. You're going to have an immune response, but you're not getting COVID. You're not getting the COVID-19 virus injected into you. Yeah. Or in this case, you're not getting SARS-CoV-2 injected into you. Yeah. Did that answer your question, Lindsay?
I'm going to take that as a yes.
I am too. Any other media questions?
Offline.
All right, Jill.
Yep, we got lots.
I bet we do. We've talked so long already.
We appreciate the people who write in. Donna wants to know about following up with testing. She wants to know, how do you know, Dr. Gerard, that you're doing enough testing on campus? Great. How would you know? And she's also, her second part of the question is, what are you doing about the parties? Can you explain what that public health ban means?
Yeah, why don't we take on the first question first? Are we doing enough? Because you're doing symptomatic and surveillance. We haven't really talked about how we're doing both.
Right. So, working with the team, we've modeled what we think is enough to get a good sense of what prevalence is on campus. And so we're doing about 500, 550 tests a week of random samplings of various groups, students, faculty, and staff.
So that's the surveillance.
That's the surveillance piece, and that's really designed mostly to help us know what's happening in our community.
I think that's actually, in some ways, you can do this. You do the symptomatic testing for the individuals and go to quarantine.
You need to do.
You got to do that.
Yes.
The surveillance thing is what we don't do in the United States, which is a problem because we can't ever really establish where we are. So I think that this is actually a brilliant thing because it really tells you the real health of the campus. And I think that's like a really important part. We probably will spend a couple of minutes.
Yeah, no, I really think it is important. And whether that's the right number or not, I think we're going to learn. This has been a learning process for all of us. We don't have a playbook for this. And so that's where our pandemic medical advisory team and the work that our health partners who meet daily to talk about these things, we learn every week with this, and so that's our current strategy. We'll see what those numbers look like, and we'll morph as we need to, if we need to do more testing in one area or in another area. But making sure we had enough symptomatic testing was key, and that's where standing up this new swab clinic for us, which is a drive-through clinic in one of the Naismith Hall parking lots. Just gave us that capacity that we think we're going to need as we go into this. And
those positive patients are reported to the state, county, and then to the state. So there's like any other positive patient at that point.
Oh, absolutely. I mean, it all gets collected eventually. Now, it comes in at different times in different places, and that's sometimes why you see the numbers bounce around a little bit, because it doesn't all come together instantly. So it is important, I think, to take that longitudinal look that Chris was talking about, because it does ultimately get there. And so as you watch what's happening over the last 7 days, that's a pretty good look at what's going on. So
as you look at, is the campus safe or not safe? We need to take additional action. Is it the symptomatic testing or the surveillance testing that's going to drive that?
I guess I would talk to Chris too, but I think the answer is both.
I think it is too. I think it is both. But I think that surveillance is really important, Chris Wilson, because that's really what's going to tell us how many people. Otherwise, we're getting a lot of symptomatic people. Okay, we do that every day, but the surveillance thing is really key to tell us how the campus is behaving.
Yeah, obviously we always wanted to take care of the symptomatic individuals as quickly as we can, and there I'm probably prioritizing capacity of testing to make sure that we can get those individuals tested as quickly as possible. And then on the prevalence and surveillance side, we're looking at randomized samples of different segments of the population to give us an indication of what positive and positivity rates might be within those individual groups, would then allow us to reconfigure either the volume of testing broadly, the volume of testing within specific groups, but it also informs things beyond testing. So does it inform, do we have an issue we need to look at from a distancing or a masking standpoint in certain populations? Are there groups within the campus that we need to do more education with? And then kind of take it a step further to the question that was made earlier, are there groups in particular we need to focus on from a vaccination standpoint once we get to that stage in the pandemic response?
Yeah. And Chris, maybe you could elaborate a little bit. I think on Friday we'll be getting the first look at our forecasting tool, which takes this data and then puts it into another tool to give us a forward projection anyway. Maybe you could talk about that a little bit. And I know we'll have a chance to probably talk about it in the future when we have that ready to demonstrate, but hopefully that'll be by the end of the week. So maybe you could just give us a little preview.
Yeah, now that we're a couple weeks into the semester, we felt it was a good time to develop and release a 2-week forecast. We'll at least start with 2 weeks and see if that's the right interval for forecasting out what the case rates look like on campus, both from a daily case rate standpoint and a cumulative case standpoint. But the idea with that is that how can we project needs that are going to be occurring on the campus in the foreseeable future for things like testing capacity, clinic capacity, but then also allow that to help inform needs in the community from the standpoint of whether it's hospital utilization, whether it's ICU beds, ventilation capacity, and be able to not only keep the campus safe, but also help with the resources and the safety of the community beyond the campus.
Just a few shout outs, because this is a combined effort. The modeling is a big deal. We've had a model, but we just were using prison data to help us figure out the dynamics. Now we're actually using campus data, which is a huge win. A couple of shout outs around that, though, because it's the health system folks with Chris and David Wildstein, but also the school of medicine people.
Absolutely.
I think Dr. Rojo, Dr. Samari have been pivotal in that, along with Ed Ellerback, Tammy Gurley. I mean, there's a lot of people who put a lot of time on that, and the university's done a great job of helping build this modeling with the business intelligence team on the health system side. So lots of great people have been working on that.
And I think that, Chris, correct me if I'm wrong, but that's really taking historic data and then projecting forward. And the other thing I think that can help us all do is that policy changes need to be made. If we're seeing things headed in a direction that we're uncomfortable with, are there additional policy changes that can be made at the county level, city level, university level that can change the trajectory of that
Yes.
curve?
Well, one of the struggles in all curves, COVID, and we learned this early on, we learn it every day, Dana, is that you're using some reference point to try and figure out how the virus behaves. So when we originally developed the one for Lawrence, the KU campus, we actually did use some prison data to try and figure out how the numbers could go. We all knew that wasn't really the exact Lawrence game. That's just a different dynamic, but it's one we had readily available to try and base it off of. Now we can use our own data, and I think that makes a world of difference for how we think this is going to act.
I think hopefully a much more predictable forecast than just a guess, which is a little bit where we were, quite honestly.
In fact, Hawkeye, what is it we always say? We're building
The airplane while we're flying.
Fly it.
Changing parts, all that stuff.
Can I ask just a quick question, Hawkeye, about your thoughts about the intersection of influenza and COVID, vaccines for influenza, recommendations on that, and really what that's going to look like as we go into the fall. I have a lot of concern about that on campus. We always see a lot of influenza on campus.
Yeah, that's a great question. We did talk about this today with our ICU director's call, led by Mario Castro and Louis Satterwhite, and Lee Norman was on the phone as well. So we know we are getting into influenza season. We've also had our influenza vaccine task force here at the health system, and we've talked about that exact thing. So still, it is fully recommended for anybody 6 months of age and older to get the influenza vaccine. That has not changed.
And it's available, but we're saying probably the 1st of October would be an ideal time to get it. You get it too early, and then when March comes, your window may be starting
waning.
to run out. And you don't want that. So really, the 1st of October.
Right, and we don't want that big push at the end where there is a large amount of influenza activity. Right now, there is a very low influenza activity in the United States, so it's not as important.
And very, very low, just to say, in Kansas and Missouri.
Yes, absolutely. Yeah. And so as we move forward into October, think about getting it at that point. How do you get it how do you get the vaccination in the age of COVID-19? Well, at this point in time, the CDC guidance, and this is what we talked about with one of our vaccine experts, Kevin Alt here at the health system, you can still give it with mild disease or no symptoms. It's not going to change other than any different than if you were otherwise had a cough or cold and you were going to get influenza vaccine. If you are significantly ill, fevers, all that in the hospital, on the ventilator, you probably want to wait 14 to 21 days. But if you have mild or no symptoms and you just recently got diagnosed with COVID-19, you can probably still get that vaccination. If you're in the outpatient setting, it's not really recommended, mostly because you should be in isolation anyways if you have been diagnosed with COVID. So at that point, you'd have to wait till your isolation period ends. So that's the main goal. Is we don't want you out in the community, going to the doctor's office, going to other places if you've been diagnosed with COVID-19. But otherwise, just the illness itself, you can still get the vaccination.
And the other thing we're saying is that if you're getting the vaccination, you may have symptoms for 48 hours. You don't need to get a COVID check unless those symptoms go on for more than 48 hours.
Right.
But if you do have some significant symptoms, we do want you to go ahead and shelter at home. Even if it's just you think it's all due to the influenza vaccine, if you start getting a little fever, still cough, just shelter and stay at home. If after 48 hours it's all gone, you don't have COVID. But if you still have symptoms, then we're going to go ahead and test you for
I get
COVID.
that pretty reliably after my flu shot. So it's just I know what it feels like.
Yeah, that's exactly it. That's what. But we do want everybody to get vaccinated.
Yes.
Huge point, and we don't think there's going to be a problem once COVID vaccine comes out. We're hoping the first of the year thereabouts. But I'm the eternal optimist. I always say that. I don't think there's any problem with getting the COVID vaccine and influenza vaccine in the same season.
So far, there's been no guidance or any other information to suggest otherwise. You can probably get them both.
And you can get shingles and influenza at the same season. So what the heck? So I don't think that'll be too much of a problem.
I think Dr. Weil did share with me that what we're seeing in South America, Southeast Asia, New Zealand was all the things we're doing to keep COVID spread down. Does help for influenza.
We've talked out a lot. They actually have a very low influenza number. The numbers coming out of Australia after an initially bumpy start are actually great.
Yeah, it's really good. Again, all of these countries, it's hard to subscribe everything to other countries in the United States because our United States experience has been different. The communities are so different. There's a lot of culture differences, and I mean, public health culture throughout our communities in the United States. But hopefully everybody will continue to get on board, do the right thing, understand about masking, physical distancing, washing your hands, not going out if you're ill. All of that stuff will help to reduce influenza rates as well.
All right. Next
Debbie's
question.
concerned about students that might need to be quarantined. She wants to know, how are you caring for them? Where do they go? Who's feeding them? Who's giving them medicine? And do you have any?
Are we still feeding them?
We try and feed and water everybody, but including our faculty and staff. So we provide quarantining for those that are in our student housing. And if they're on off campus, we expect them to quarantine wherever they are, if that's in their apartment or their room in their house, if they're sharing a house with others, or to go home, which some students have opted to do as well. We set aside a separate dormitory for quarantining and isolation, both. And we deliver food to them. They can order basic medicines if they need them. They can order what they need there. But really, we've just taken them out of their communal living environment into a non-communal living environment for the time that they need to shelter. And it's but they couldn't really do that in their communal living environment safely. So we had to create a separate.
How many students can be in? It's a nascent.
Yeah, we've got at least 200 that we can handle, and we actually have some spillover opportunities as well if we needed to go beyond that. We haven't pushed that limit yet. I think we've never been over 100 total, but so far. And of course, they're cycling in and out all the time.
Of course they are.
As their time comes up, they go back to their own living quarters, wherever that is, and new ones come up. So, and then they, of course, have access to Watkins Health Clinic. That's really the only reason they can leave is to go to Watkins if they need to go get checked out for something that's going on.
With all the right infection control processes in place. So.
TAP wants to know, how are you confirming that someone has been exposed to COVID-19? Talk about your contact tracing.
So if it's from one of our tests, meaning on-campus testing, whether it's through Watkins or the health system, or when LMH was helping us do our entry testing, we would get all that information in one place, and then we would reach out to every single positive case and have a conversation with them. Now, the county does true contact tracing, and that's just how legislatively we're set up in the state of Kansas, but we do reach out to them, ask them how they're doing, give them instructions on what we expect in terms of isolation and quarantining, suggesting that they get a hold of their direct contacts, but then the county follows that up with another call, usually a few days later. They get the information a little bit later, and they will do more directed contact tracing. But we try to do a preliminary step at the university level, and then the county layers on, and maybe Chris can speak to that better than I because he's intimately involved with that process.
Yeah, that's right. So the campus, through the Watkins physicians and clinicians, will do an initial contact collection from the positive cases that have been identified. And through that process, the county actually gets sort of a heads up on who those contacts might be, so they can start to prepare not only about how they do their disease investigation for the positive case, but also the close contacts of that individual. If in the meantime, while the county is continuing with their process, the close contacts of that positive that have been self-identified and the clinicians on campus confirm that and have a conversation with those individuals, those are the individuals that we talked about earlier that are able to come and get a COVID test 7 days after their exposure. And so while at times we may have some delays in the formal disease investigation process, we've tried to expedite some of the interventions that need to happen in the meantime by doing this contact collection and preliminary testing of the individuals that may be exposed to the positive.
All right, time for one more question, Jill.
All right, sort of off topic but related. Quetta wants to know, she and her husband both are COVID positive. She and her husband are both in the hospital, separate hospitals.
Oh, ouch.
She does say they are on the mend, but she wants to know, they are so worried about going home. Are they going to get it again?
That's a great question, Dana. Man, that's a tough story.
Yeah,
especially that separate hospital part.
Yeah.
So let's think about when people start getting better and they go back, are they okay to be around each other?
I think it sounds like they're both having the same disease process and timeline. I think once they are able to get out of the hospital, I don't see a reason why they can't go. They are normally in their bubble together. I don't see a reason why they can't go and be together in their household or their bubble. Can they get it again? So far, what we've seen is that there can be reinfection. Now, we don't know all of the dynamics of that and all the data and information about that, but we've obviously seen at least two really well-done studies on cases of reinfection. So there is that possibility there.
It seems unlikely so early in the course of the disease. They would get,
right. The first one was at least 140 some days, so at least 3 or 4 months. But we don't know exactly when you do get it again, what your symptoms are going to be, how that's going to really interact. For the time being, for the short period, we would certainly hope and believe that you have immunity to protect you from the illness again. And if you have disease and illness enough to be in the hospital, there's a chance that your immune system, your immune function for that disease is probably higher than somebody who we say has no symptoms or mild symptoms. We've seen that antibody levels tend to be higher in the patients with more severe disease, so you may have a higher level of protection, say, than somebody who wasn't ill enough to go to the hospital.
Yeah, here's how I'm going to answer that question. I think that if you're within 10 days of being tested and you still think that, which is kind of the viral shedding period, and you're home and you're with each other, I'd wear a mask.
Yeah.
And I think once you get beyond 10 days, I think you're pretty safe. And I think that's probably less of a concern. And we just hope that our listeners are on the mend and going to get better. And it's got to be good to think getting to see each other again, as opposed to having just by FaceTime or on the phone when you're in different hospitals. But as you do come together, still maintain good infection control, especially with the first 10 days after you've been diagnosed. So I think that's the real key. Hey, Chris Wilson, final thoughts for this morning.
I think we did a 20+ thousand tests initially upon entry throughout the month of August to campus, and now we're at a stage where that data has been really critical to help inform decision making on campus. So not only does the testing process help identify positive cases and isolate them and help prevent spread, but it also helps us be more strategic and surgical with the interventions that we can use going forward. And now at 26,000 some tests, we've got lots of data points to help inform the conversation through the rest of the semester. And so really, really proud of the team that's all come together to help make that happen. That's not just a county team, that's an LMH team, that's a county team, that's a health system team, that's faculty members, that's staff, that's students. So we're really pleased with the collaborative effort that we've had so far in this process.
Chancellor?
Yeah, I couldn't agree more, and just so appreciative of the partnership of all those entities that have really come together to inform, to modify, to monitor, and to really create, I think, as safe an environment as probably exists in America right now on a university campus. So
yeah, I think it is exactly that. Yeah. Hawkeye?
Yeah, I think as we move forward into this and we get more testing capacity. Hopefully saliva will come online as far as diagnostics. Maybe the antigen testing. That surveillance testing can do even more to keep everybody on campus safe, including my old mentor, Matthew Buechner, up there in the worm lab, because I think testing is the way to, number one, understand, again, how much disease is out in the community, what is the prevalence, and also the way to keep it from spreading more. Because if you know you have it, you are going to be isolating, you are not going to be around spreading it around as well. So.
We said early on that it was a mass migration of 20,000 students into the community, and that we had to almost have a mini health department on the campus. And I think everybody together, Watkins, KU, the health system, LMH, have come together working with the county health department in Douglas County. I think that's exactly what happened. And I think that's one of the reasons I feel safe about this. I mean, I think it really is an excellent example. It's also an excellent example of what happens when we work together. Not about Democrats, not about Republicans. It's about people trying to work to keep each other safe, to keep a community safe, to keep a campus safe, trying to do the right thing. And that's what will deliver the best outcomes from COVID-19. Hey, tomorrow, pretty cool stuff too. We try to be cool every day. Some of us are more cool than others. Hawkeye. So tomorrow we're going to hear from the western edge of the scenic Flint Hills in Clay County and the county seat of McPherson County in Kansas, when CEO of the Clay County Medical Center, Austin Gillard, and Chief Nursing Officer at McPherson Hospital, Beth Ward, join us. They will be joined by Jody Smith, the Executive Director of our Care Collaborative, which is our program that goes across the state trying to improve the health of Kansans. Together, they're going to help us tell the story of a statewide clinically integrated network trying to fight COVID-19. Pretty big deal, and I think great to hear from folks out in outstate Kansas of what's going on. Finally, we're closing in on the finish line of our 50 reasons to love your mask. Now remember, there's 50 reasons to leave your lover. That's not what this is. It's not 50 reasons to leave your mask, 50 reasons to love your mask, besides trying to hide the rosacea on my nose or the pimple on my face or the fact I can't use a razor correctly. We'll keep taking submissions through Friday. Please send us those, and as well as your mask-wearing pictures. We also have a mask submission from Megan, who writes, "You asked us to show how mask wearing allows us to do the things we love. My daughter and her friend Lucy love ice skating." Look at them go. They're pretty darn good out there. Yeah. They are adamant about mask temp checks and safety measures. Their coach Bonnie took this video. Keep each other safe, we get to normalcy a lot faster. When we don't keep each other safe, you see, that's when trouble comes. So stay out of trouble. Shelter in place when you can. Get out in public, but when you do it, wear a mask, wash your hands, keep your distance when you're sick, stay home when you are sick, cough into your elbow, all the things we know we talk about every day. Yeah. The pillars of infection control, which go with you wherever you are, whether you've got to college or you're going to work.